Good afternoon, everyone. My name is Nirav Shah, and I'm the director of Maine's Center for Disease Control and Prevention. And I'm joined this afternoon by Commissioner Jean Lambrou from Maine's Department of Health and Human Services. Commissioner Lambrou and I are delighted to be able to join you all today to provide you an update on where we are with COVID-19 across the state of Maine for today, Friday, January 8th, 2021. And I'd like to begin by talking about where we stand with respect to the number of individuals who have passed away with COVID-19 statewide. Many of you may have seen that there were 41 additional deaths reported today. This number alone is a stark indicator of the toll that COVID-19 is taking on all of us. We share our condolences with the friends, families, loved ones, and communities of all of those individuals. However, what I'd like to talk about right up at the top today is what that number means and what it does not mean. Of those 41 individuals who have died with COVID-19 that were reported by Maine CDC today, 6 of those individuals passed away within the last 48 hours. 35 of those 41 individuals died at some point during the month of December with COVID-19. So why are we reporting those 35 additional deaths today? Well, I'd like to take a moment to walk through this process, which I hope will illuminate why 35 of those 41 deaths, even though they occurred in the preceding 4 weeks, are being reported today. Maine CDC has a multi-layered process to validate the data that we receive on COVID-19 deaths to make sure that those data are both accurate and complete. Again, to explain this, it's helpful to dial back a bit and start at the beginning. How does Maine CDC even find out about COVID-19 related deaths? Well, there are a few ways. One way, for example, is if a patient who's hospitalized because of COVID-19 dies while they are in the hospital. In those situations, the hospital contacts us, and we typically hear within 24 to 48 hours of the death. Another way that someone may die with COVID-19 in Maine is if they happen to die during, for example, an outbreak at a long-term care facility. In those situations, the administrator of the long-term care facility may alert the epidemiologist at Maine CDC who is investigating the outbreak that there had been a death. And that process occurs, and that can be another way that we find out. Yet a third way is that on certain occasions, the medical examiner or funeral homes will notify us of a death that they are handling that was associated with COVID-19. Sometimes those occurrences are reported to us immediately, and as we've talked about in recent days, as some questions have come up, sometimes that process can take many, many days before they're reported to us. But there are a certain number of individuals who die outside of any of these settings. We don't want to miss them or undercount them. So as to make sure we are accurately reflecting all of the potential individuals who may have died with COVID-19, we have a safeguard process in place that goes one step further. Our epidemiologists receive information on deaths from our colleagues within the Maine CDC from a different office, the Office of Data, Research, and Vital Statistics. This is the office that handles, processes, stores, and analyzes, among other things, death certificates. From time to time, Maine CDC's epidemiologists scan those death certificates to look for information suggesting that the person who died may have died related to COVID-19. We use things like what are called ICD codes, codes that classify injuries, diseases, and deaths. We also look at the text fields that the person who filled out the certificate may have entered in to look for words like COVID-19, or the diagnostic codes that signify that the person may have had COVID-19, but died outside of the arenas that I mentioned earlier. When we find those, we match those back to our database of cases of COVID-19. And if we find indications from the death certificates that were not reported to us as deaths already, we look into them. And if we find that they meet the criteria to be classified as a death with COVID-19, they are included in our count of deaths. That is what has happened here today and what we are reporting out today. After reviewing cases of death reports from vital records over the past few weeks, we identified these 35 individuals whose deaths had not been otherwise reported to us directly, but upon our investigation were found to be COVID associated. This process is part of a multi-layered approach to validating our data, to making sure that they are accurate, and in this case, making sure they are complete. The bottom line here is that this is a morbid topic. These deaths are all associated with COVID-19. They did not happen all within the past 48 hours. Indeed, 35 of the 41 occurred over the past several weeks. But that does not diminish their import one iota. They are all just as tragic. And the families of all 35 of those individuals, to say nothing of the 41 individuals in total we reported today, feel all the grief that comes with a death associated with COVID-19. So as always, I'd like to take a moment to offer our deepest condolences to the friends, families, and communities of all of these individuals who have died with COVID-19. Overall, across the state, well, I'm sorry, as I mentioned just a moment ago, I apologize, of these 41 deaths, 6 of those are deaths that were just recently reported to Maine CDC and have occurred since the last time we spoke. Those deaths are a woman in her 80s from York County, a woman in her 90s from Aroostook County, a man in his 80s also from Aroostook County, a man in his 70s from Cumberland County, a man also in his 70s from Penobscot County, and a woman in her 70s from York County. Again, we offer our deepest condolences to their friends, families, and communities during this time of their grief. Right now in the state of Maine, there are a total of 28,407 cases of COVID-19, representing an increase of 782 new cases just since yesterday. Of those, 23,803 are confirmed cases and 4,604 are probable cases. Cumulatively, 1,150 people have been hospitalized at some point. And right now, just in the state of Maine, there are 205 people who are in the hospital with COVID-19. Of those 205, 56 are in an ICU bed and 26 are on a ventilator. As I mentioned a moment ago, cumulatively, there have now been 426 deaths associated with COVID-19. And of our cases, of our 28,000 cases, 3,041 are among healthcare workers. Turning a second to a few outbreaks that I wanted to take a moment to highlight. One that I wanted to note is an outbreak that Maine CDC has just recently opened into 4 cases of COVID-19 associated with the Howland Fire and Ambulance Division. We are working with them to make sure that they have access to testing as well as investigating how that outbreak may have started. We're also opening a preliminary investigation into an outbreak associated with the Portland Family Shelter. Both of those investigations are in the early stages, and we will have further updates as they progress. Turning next to some metrics around testing. For PCR tests, the 7-day positivity rate in Maine now stands at 6.06%. And the PCR testing volume stands at 510 PCR tests for every 100,000 people. Turning to antigen tests, The antigen positivity rate right now stands at 8.5%, and the testing volume for antigen tests stands at 117 per every 100,000. One very brief note on the antigen positivity rate. A positivity rate of 8.5% may seem concerning. There are reasons, however, to think that that positivity rate is actually a reflection of proper usage. One of the things that the scientific and public health community has learned about these antigen-based tests in recent weeks and months is that they perform the best upon individuals who have symptoms already. When you've got symptoms of COVID-19, the antigen tests seem to be better at picking up the disease, as opposed to using them in individuals who have no symptoms. The fact that the antigen positivity rate has ticked upward may be an indication that those tests are now being used in symptomatic individuals who, at baseline, are more likely to have COVID-19 than someone who has zero symptoms whatsoever. We are keeping a very close eye on this to determine whether this increase in positivity rates is a function of more appropriate and focused usage versus a function of more disease transmission. And finally, I want to turn to vaccines. As of this morning, there have been a total of 46,633 doses of COVID-19 vaccine administered. Here's how that breaks down. Of those 46,633, 43,362 people have received their first dose, and 3,271 people have now received both of their doses of COVID vaccine. Among all 46,633 people, approximately 2,250 of that larger denominator are EMS clinicians who have received at least their first dose of COVID-19 vaccine. And turning now a little bit to where we are going forward. Yesterday, over the course of last night and this morning, Maine CDC has placed, and Maine DHHS have placed our orders for allocations of COVID-19 vaccine for next week, the 5th week of allocation of distributions, which begins on January 11th. In total, as a state, Maine will be allocated 17,175 doses of COVID-19 vaccine. That breaks down into 8,775 doses of Pfizer vaccine and 8,400 doses of Moderna vaccine. To put that number in perspective, that is only 100 doses more of COVID-19 vaccine than we got this week. And it's only 100 more by 100 additional doses of Moderna. Candidly, we were hoping for increases in the volume, but next week, as with this week, it appears that the volume that we will receive will be flat. Of those 17,175 doses, 4,875 will be allocated to the partnership with retail pharmacies to vaccinate residents and staff of long-term care facilities. What does all of this mean? Well, among other things, it means that we are squarely still within group phase 1A. That's a group that comprises roughly 130,000 people. And by the end of next week, not this week, but next week, 1 week from today, we will still have received vaccine sufficient for only roughly 75% of that entire group. That's not this week, but that's by the end of next week. Now, in terms of vaccination velocity, we are making strides. Both yesterday and the day before, over 4,200 vaccinations were reported to Maine CDC, a pace that we hope will not just continue, but continue to increase. Now, I want to be clear, these snapshots, like so much with respect to COVID, are moving targets. So the trends that we observe are what matters. And here, the trend is encouraging. Earlier this week, on January 4th and 5th, there were roughly 2,100 to 2,500 doses per day that were being reported to us as administered. And now in the recent 48 hours, that number has continued to increase. The slope of that line is going up. And for the first time in a long time in this pandemic, we're in a situation where an upward sloping trend line on a chart is finally a good thing. We continue to work with hospitals and healthcare systems to increase that velocity so that as many shots in arms can be delivered every day. Before I turn things over to questions, I wanted to answer two questions that have come into us about COVID-19 vaccinations just in the last 48 hours. And those two questions, the most two common questions that we've received are, well, number one, why do I have to get 2 doses? And number two, why am I being told, or why have I experienced a fever or a little bit of pain or muscle aches after I get the vaccine? Why does that happen? Let me first start with why you need to get 2 doses of the current vaccines we have. The current vaccines we have start priming your body's immune system after the first dose. They tell your body's immune system, here's an example of a virus that if you encounter it again, we want you to be ready to fight it. That's how they both work. They show your body a little snippet of a little particle, that spike that's on the virus that we've all probably seen in pictures. Sometimes it's red, sometimes it's orange. It's probably not that color in real life, but the vaccines show our bodies just that little spike, and that tells the body to be ready. But that first dose may not completely prime the immune system's pump. The second dose is, based on the data we have, the booster shot, something that we're all familiar with. It not just helps the body keep ready, but it increases the duration for which the body will remember that picture of the vaccine, of the virus rather. So that if the body gets exposed to the COVID virus in the future, both of those doses will be fully on board and the immune system will be ready as long as we know it can be to react on its own to start tackling the virus. There are some data to suggest that 1 dose has some impact. Indeed, according to one publication, 1 dose maybe gets you about 50% protection. But when we get both doses on board, the immune system is fully fortified, and that's where we get the 94 and 95% effectiveness. The first one is the foundation, the second one is the booster shot. Which takes me to the second question we've gotten a lot recently, which is, why do I get a fever? Or why might I have body aches after the vaccine? Well, one of the things that vaccines do is, again, help prime your body's immune system pump. It shows the body a little harmless snippet of a virus and starts the immune system working to prepare so that if you get a bigger dose of the virus in the future, the immune system's ready to go. One of the things we've all felt when we feel ill is that fever, that headache, that feeling of just being run down. That is in part because our body's immune system is spinning up, activating, getting ready to tackle the virus. What vaccines do is provide a little glimpse at that, a modulated, lower level immune response that gets the body ready to tackle a higher set of doses of virus if they encounter it in the future. Those fevers, that muscle ache, that maybe small headache is evidence that your body's immune system is responding to the vaccine and getting ready so that if you see the virus in the future, you'll be ready to go. Does it happen in everybody? No. And if you get the vaccine and you don't have a headache or a fever, does that mean it didn't work? Not at all. But it does happen in a few people, and it's important to know that if you get the vaccine, you might have a slight fever for a day. That's not a bad thing. It's not unexpected. It's not even a side effect. It is an effect of the vaccine doing its thing, getting your body's immune system ready for the future. So with that, I'm going to turn things over to our colleagues in the media. Commissioner Lambrou and I are happy to answer any questions you've got. I'm going to ask Patty White to kick us off this afternoon.
Thank you, Dr. Shah. Can you tell us what the progress is for vaccinations in the long-term care and pharmacy program? Do you know how many doses and what % of that group have been vaccinated, and are you satisfied with that progress?
We do have those data as of about 48 hours ago, Patty. I do not have them at my fingertips, but we do have them. We asked for, I should say, at our request. We requested, more than requested, we wanted to get those data, and we got those data from CVS and Walgreens. We will get them over to you, Patty. Again, I don't have them at my fingertips, and I don't want to mischaracterize them, but we will get them over to you. What I will say is that there are a few things happening. The rate at which clinics are being scheduled is hitting its stride. Those clinics have started to get scheduled with the velocity, the regularity that we were hoping to see earlier. That's a positive sign. But we've also seen some concerning signs in the data about uptake. So we're working to make sure we understand the data fully, to make sure we understand what they represent and what they don't represent, and then trying to see whether we need to do additional outreach to make sure that when those vaccinators come on site, the uptake rates are what we're looking to see. Again, I don't want to mischaracterize them. I have some recollections of them, but we'll get you the exact numbers, Patty.
Do you remember, in terms of uptake, is it among staff and residents?
Yes, it was. The data were broken out by both staff and residents. And I want to make sure that what the uptake numbers were not of all residents or staff in a facility. You really want to do uptake based on how many were offered that day. And that's what I want to make sure we shore up. If there are 400 people in a facility, but the first clinic only offered vaccine to a third of them, 133 of them, you can't use 400 as the denominator. It can only be how many were offered that day. And I want to make sure that we get that answer straight first.
Great. And you had mentioned before that you had concerns about the number of pharmacists available to administer the vaccine. Is that still a concern?
Patty, I don't want to answer. I really do want to go into those data a little bit more because I'd like to see and spend a bit of time with my team to see whether the rate at which clinics are happening and the throughput that they are able to achieve at each of those clinics is what we think it should be. We have spoken directly with the pharmacies at all levels to emphasize that they need to be fully staffed so that when they go on site, they can vaccinate everybody on that day who is slated to be vaccinated. I don't want to mischaracterize them. And so I'm at this time, rather than getting it wrong, I'm just not, I haven't dived into the data. We've just gotten them in the last day or so. And so we've had those concerns, whether they have been ameliorated and addressed. Rather than misspeaking, I'd rather review the data a bit more closely.
Understood. One other question, as you're figuring out logistics for ramping up vaccinations in the future, are you considering schools as potential sites? I've heard from school nurses who are eager to be a vaccination site.
Well, Patty, that's on our list. The thing is, and we have agreements in place with many schools to utilize them for different types of applications in this realm. The real question here is, if we're looking at doing, the real question here is, given the number of vaccines that we'd like to administer at these sites on a daily basis, whether the, say, school gymnasium has the appropriate space, ventilation, traffic flow, parking to accommodate that. Also, I think it's important to note that this large-scale community-level vaccination effort will take many, many, many months. Whether we can occupy schools for that long period of time is an open question. So it is definitely a part of our planning process, but there are these limitations that we have to reckon with: size, the longevity of this program, so on and so forth.
Thank you.
I'm going to turn it over to Eric Russell next.
Thank you, Dr. Shah. I had a couple of questions about vaccines as well. the math is fluid and the numbers change quite a bit, but it seems like if we take into account all the doses that Maine has gotten from in the last 4 weeks, and compare it to how many vaccines have been administered based on the dashboard online, it's about half. Is it that you're holding back the second dose, or is there another explanation?
No, actually, Eric, I suspected a question of that sort today, so I want to take it head on.
Okay.
I respectfully disagree both with the numbers and and perhaps the characterization you were aiming for. So, of the doses that we have received, it's important to note that approximately a third have been allocated for the retail pharmacy partnership. Those allocations started weeks ago, way back in December, for clinics that we knew would spread or span over a multi-week period. Again, those clinics will happen at each long-term care facility times 3. They don't go in and do everyone at once. They do them over a 3-clinic phase. One clinic and then another one 3 to 4 weeks later for the second dose, and then a third clinic 3 to 4 weeks after that for other folks who, so it's 3 phases. 3 distinct clinics, but we have committed those doses up at the front. So right up at the top, that's a third of our doses. When you subtract those out, what we've vaccinated thus far, over 40,000, is as a fraction of what was available, pretty close to what we've received by the end of this week. I'm not going to just list off a litany of numbers because it just gets to be a lot of numbers, but we can get those for you. Based on the pace that we've achieved just in the last 48 hours of 4,000 or so doses a day, we are at the point where we are really utilizing much of what's coming in the door and getting it out and getting it into arms. Again, I'm not going to read off a litany of numbers, but we can get those over to you.
Okay, well then can you just clarify that the number that's on the dashboard, does that include updated regularly with what's happening with the pharmacy clinics?
It does. However, important to note, and this is just a feature of how that program was structured. Providers in Maine, hospitals, primary care, EMS, they are required to report to us within 24 hours of administration. The pharmacy partnership, we did not structure it. It was structured at the US CDC level. The pharmacy partnership has 72 hours to report to us.
Okay.
And so there is that lag. That is a feature of the program, and it means that we don't always have the latest up-to-date numbers of pharmacy versus non-pharmacy. And then, Eric, one small thing you mentioned, does this, the numbers that we get do not reflect second doses.
Got it.
Sorry, so the allocation numbers I read off earlier, those are first doses, not second doses. There may be some changes coming to that in the near future, but that would be at least 12 days away.
Okay.
And I would note that we did post on our website today for the first time that breakout of first doses versus second doses, because now that's become more meaningful.
Mm-hmm.
And you said you provide those numbers at some point later.
Yes. Yeah, we can get you the roll-up of, at the end of at least what has been reported to us today, what's been available to get shots in arms by hospitals and EMS, how much has been allocated and how much they've done. Again, I've got it, but spending 3 minutes on the air reading off a bunch of numbers is, yeah.
I understand. The last question I had, there's been some conversations with the independent healthcare practitioners, and it's my understanding that maybe there were some conversations today with that group about setting up some clinics. Can you touch upon that?
Sure. Commissioner Lambert,
Sure. So we recognize the fact that in the interest of trying to shore up our critical care capacity in our hospitals, our emergency rooms, our EMS teams, we also have community-based providers that are not necessarily employees of hospitals who needed to get vaccination to make sure our capacity in the state of Maine was strong. So beginning last week, we've been working with both the professional associations, other organizations of these healthcare providers, as well as with the sites that are willing and able to schedule them to get them vaccines, to make sure that they're talking to each other. They basically are trying to figure out, okay, we had this number of practices in this area. What are the hospitals and outpatient sites or FQHCs in these areas that are willing and able to vaccinate these people. So it is not a perfect system. We are trying to get to a much more efficient way to ensure that people in these categories get vaccines, but we thank the Maine Medical Association, Maine Osteopathic Association. Today we're talking to a bunch of the allied health professionals to try to figure out how we can, again, connect those people who are healthcare providers in this group, these groups that we're trying to get in first, with those available sites that will vaccinate them.
Okay, so future doses that come in could be earmarked for those particular clinics, just like they have been for hospitals already?
For this week's allocation, or the week 5 allocation that we're announcing today, is primarily for this purpose.
Okay, thank you.
Yep. I'm going to turn it over to Amy Brown next.
Thank you, Dr. Shah. You, I'm sure, are aware that it was announced this morning that the Biden administration is planning on releasing all of the vaccines at once rather than holding back the second doses. Will that present any type of problem with storage?
You know, Amy, a moment ago, I mentioned in connection with Eric's question that this second dose thing may change a little bit in 12 days. That was what I was referencing there. You know, Amy, with the incoming administration has not officially released their plan and their concept of operations. I suspect that they will refine that, communicate it to the US CDC and Operation Warp Speed, and then states will be briefed on what that will look like. So at this time, I can't provide specifics. What I will say and emphasize is that for weeks, months, at our warehouse at the US CDC, at the Maine CDC, in our warehouse, we have been planning to be able to store very large volumes of vaccine, be it the Pfizer vaccine in ultra cold storage requirements, the Moderna vaccine in normal frozen requirements, and even other vaccines in refrigerated environments. So we are prepared to be able to store a very, very high number of doses, as are healthcare providers across the state. But without knowing the specifics of the plan and what their allocation cadence might be, I can't comment on it, but I will say that we have been prepared for months now to receive very large boluses of vaccine. Once we've reviewed and once the incoming administration has really put out their plans and told us what that will change in terms of our allocations, we'll be able to talk about it a bit more.
Okay, great. And has it been determined, or is it possible to determine with the reduction in contact tracers and case investigators, how much of this big spike in cases that we're seeing now, exactly 2 weeks after Christmas, is related to holiday travel and gatherings?
So one note there, Amy, one important factual clarification. There has not been a reduction in contact tracers or case investigators. Indeed, the dial has been turning the other way. We are up to about 165, maybe even a bit higher than that. We can get you the exact number, whereas just a few months ago, we were at about 100. So we've continued to increase the size of that team, not reduce it. But to your exact question, it is difficult to divine whether any or what part of this increase is related to any specific holiday travel. It comes at a time when cases across the country have continued to go up, sadly, as have deaths. I know that our case investigation and epidemiology team is trying to get a better sense of where people may have been exposed. That process takes time. Even after we have identified the cases, which are, as you noted, starting to happen, going into those data and looking for trends that might suggest that they were connected with gatherings, that's a second order analysis. It's underway, but at this time, I don't really have any updates on it.
Okay, so just to clarify, I'm sorry, yeah, I did speak incorrectly about the reduction in contact tracers, but my understanding was they were more or less being repurposed so that they weren't investigating every case unless it's related to some kind of outbreak. So that's why I'm wondering if it's not a large gathering or a facility like a long-term care facility, are they still able to gather that data?
The answer is yes. Of course, it is a bit more limited. It's not just outbreaks that they are investigating. We haven't dialed back on outbreaks one bit. Indeed, we've, again, turned up the dial there. And we continue to investigate cases among individuals who are over the age of 50, under the age of 18, who are racial minorities, who are hospitalized, who are living in congregate settings. So and that is for the most part where many of our cases are coming from. So we believe we would have some good insight into what degree of any increase may be associated with Christmas travel. Maybe not 100% to be sure, but we are looking at that. Right now, the team hasn't come to any conclusions.
Thank you.
Going to turn it over to Patrick Whittle at the AP next.
Thank you. Thank you very much. A couple of things. I guess you were speaking earlier about the importance of uptake in healthcare facilities. That's been a little bit of a problem in different parts of the country. Although as of now, it sounds like it hasn't really been one here. What can Maine do to sort of avoid seeing the low rates of uptake that we've seen in some other parts of the country?
I'll start and then invite Commissioner to weigh in as well. And Patrick, just to be sure, you're focused on uptake rates among healthcare providers or more general?
Yeah,
healthcare
I'm
providers,
talking specifically about healthcare providers.
Yeah, or even actually the weekend that the first vaccine, the Pfizer vaccine, was authorized, that same weekend, the US CDC put out a toolkit for healthcare facilities to work with their staff to answer their medical providers' questions about the vaccines and what does it mean and how well does it work and what are some of the potential effects, things of that nature. I think as a result of that, among healthcare practitioners, we've seen uptake. Is it what any of us would have wanted this far in? No, that's never the case. It's going to take time. But to me, Patrick, and this won't come as a surprise, uptake depends on two things: education and trust. We want folks to be fully educated and aware of all the data around the vaccine. And then with that, we think comes trust. Trust that those around them, their peers, whom they look up to are taking the vaccine. Trust that the system is one that will make sure that if they have any questions, they will get them answered, that the process is overall transparent and we're working at a good clip. Those to me are the two foundational principles to getting high uptake. I think because of the work that healthcare providers, hospital systems, EMS clinicians have done in preparation for this, both of those things were in good place when the vaccine started coming out. The educational piece and the trust piece. Can we do more? Absolutely. Are there things that we can do to start increasing the rates? Certainly, but I think we have started off on a strong footing.
I'll add 2 points. I'm sorry. Just one is that we have, for the past month, been doing bi-monthly education sessions with healthcare providers. Sometimes these sessions are as many as 600 people to make sure that the front lines, the doctors, the nurses, the healthcare professionals that people trust have the information to increase their trust. Second of all, the Governor Mills announced her budget proposal today, both her biennial budget proposal as well as her supplemental budget. That does include $5 million for vaccine administration. To date, we have not gotten funding from the federal government. The supplemental budget request will be there if we need it, and that will include education to improve uptake as well as all the system changes we need to efficiently provide vaccine. We also hear that we're going to get about $12 million from that bill, coronavirus relief package, that Senators King and Collins and our delegation supported, that was signed into law on December 28th. While we look forward to that money coming, it's not here yet. We don't know what its uses are, but regardless, we plan as we move out of the healthcare provider vaccination effort into bigger groups that are not as familiar with the science to do a lot more in education for uptake.
I see. Somewhat similarly, regarding the statistics from today, the high case count and the high reports of more deaths. It's a little bit of a challenge to communicate to the public that these numbers do not all reflect something that just happened. And I guess I would love to know if you're sort of concerned if you have any thoughts about how we can abate that going forward, because the average person is going to look at these numbers and they're going to think, okay, that's what happened today, because that's what was reported today. And I'm a little bit, I want to make sure I'm getting numbers that are really useful in front of the public about the subject.
I appreciate that, Patrick, and I'm glad you raised that. I too have, I mean, that's one reason right up at the top today, I wanted to address this squarely. These deaths are real, and they have exacted an obvious human toll on those whom they have affected. But it is a bit like that proverbial train. What we are seeing right now are snapshots of things that occurred many, many weeks ago. And that has sort of been the case with everything regarding COVID. This case today is certainly more pronounced. It's more stark because of the numbers. It's jarring, and that's why I wanted to discuss it right up at the top. But much of what we are seeing with COVID are pictures of events that happened weeks ago. And that's always been the case. When we report a new case of COVID, we're actually talking about a transmission event, a virus going from person to person that probably happened 7, 8, 9, 12 days ago. The same thing, anytime we report a death, that is a death that has been reported to Maine CDC within the last 24 hours. Sometimes those deaths occurred within that 24-hour period, sometimes within 2, 3, 4 days. We're in a situation where things are moving so quickly. What we can talk about is what is reported to us. Sometimes that's a difference of 1 or 2. Sometimes, as it was today, when you rewind 4 or 5 weeks, a difference of 35. It is really difficult to convey. It's why I wanted to just dive into what it means for a death to be reported to Maine CDC, to pull back that curtain a little bit more. But Patrick, I concur with you. It's a difficult notion to talk about because it's morbid, but it's also a glimpse at how public health works in a pandemic. I don't really have much better to say. I'll turn it back over to you, Patrick. Does that help?
Well, yeah, certainly. I guess one of the things I'm wondering about is if we can expect to see more days in the coming weeks that looked like today. And I just want to make sure that we sort of show to the public that this is what's being reported today, as opposed to this is exactly what happened yesterday.
Yep. One of the things that we are going to try to do a bit more is, so first of all, to your first question, instances like this could happen. We query the vital records as often as we can, but as everyone is aware, there were a high number of deaths last month alone. And this is in parallel to that, although there were a high number of deaths reported to us in hospitals and in long-term care settings, this is just evidence that those were not the only places that people were dying. When deaths go up everywhere, the number that are reflected in these vital records will continue to go up. And what we are trying to do is provide a little bit more granularity on when these deaths occurred. As you can imagine, at the same time, Patrick, there is a little bit of tension there with privacy. If we mention a 60-year-old person in Piscataquis, a 60-year-old man in Piscataquis County who died on December X, and you happen to know somebody in that category, we run the risk of identification. So it's a bit of a balance, but we're trying to be as forthright as we can.
Got it. Yeah, it's clearly kind of a high wire act.
Yep, we're trying to balance all of those things: transparency, data integrity, accuracy, completeness, and privacy at the same time. I'm going to turn it over to Brian Sullivan next.
Thank you, Dr. Shaw. Just going back to, I think, the possibility that in about 2 weeks, maybe more vaccines are released. I guess the question I would have is, what would prompt the Maine CDC to expand the umbrella of people who administer the vaccine? And would it be that more vaccines become available, and just that through that process? And I guess what would be the thing that would make that happen?
Sure. Brian, again, I can't comment specifically on the proposal from the Biden-elect and Harris-elect administration. It hasn't been officially communicated to the states yet. Of course, and until perhaps the 20th, it may not be. So I can't comment on that element specifically. What I will say in general, and what I talked about on Wednesday, is that one of the rate limiting steps that we have faced is the number of vaccines. That is something that we have to contend with. But it's important to note that under any proposal in which more doses are released, if the second doses are not held in reserve, then we have to come up with a way to make sure that on that 21st day or on that 28th day, there will be a second dose available for somebody. So if we do get increased numbers of doses, are we going to ourselves put those secondary doses in reserve? Perhaps, perhaps not. If we move through them more quickly, which means more folks get their first dose, there's a production delay. If there is an outbreak of COVID at the place where vaccines are being manufactured, what does that mean? We've got to analyze these questions really, really carefully. Right now, Brian, again, until we see the proposal, until we really analyze the impact, I can't comment on it specifically. Even though increased availability of vaccines is something that we welcome, if it means that we have to take steps to reserve or guard the second doses, we may not have the same throughput. It's just an open question at this point.
So on that note, if you were to get more vaccines, would the amount of people that you currently are allotting them to, would that remain the same, or would you expand the umbrella of people delivering them? And where would you start if you did?
I can't speculate on either of those. It really does depend on what would happen with the second doses. Under the current system, we've got greater assurances that when we give somebody a first dose, that there will be a second dose available for them. If that insurance is taken away, we've got to adjust our plan. To your question about what it would mean in terms of where we'd start, difficult to say. It really does depend there on the volume.
Okay, thank you.
I'm going to turn next to Jennifer Long at WGME.
Hi, Dr. Shah. I wanted to go back to the numbers from today again. And, you know, I kind of echo what was said earlier about people being confused about the numbers, and we put out the numbers daily. There are inevitably people on social media who try to discredit them or maybe make light of the numbers, considering how much higher the numbers are in other states. I'm wondering your message to them, and if the numbers that we're seeing aren't enough of a wake-up call, what could be a wake-up call for these people?
Well, I think that it's important to note that there are right now at least 426 families in Maine who have lost a loved one in the past year, in the past 9 months to COVID-19. There are over 200 people in a hospital right now who are sick with COVID-19. There are over 50 who are in a critical care unit. And there are 26 people in Maine right now who cannot breathe on their own and have to have a machine helping them to breathe. If those numbers don't convince people of the seriousness, of the gravity and the reality of COVID-19, it is difficult to conceive of what might. These are real people who are suffering real consequences. Now, I'm aware of folks who continue to believe that this is just the flu. And I guess what I would say to them is to ask any of the families of these 426 people if those family members think that this is just the flu, because I assure you that they won't believe that.
I know we've talked a lot about vaccines today. Is there any talk about more regulations as the numbers continue to tick up? We've seen evidence that it's not working as well in other states, these stay-at-home orders, or are all of our metaphorical eggs in the vaccine basket at this point?
Yeah, I don't think any final decisions have been made there in terms of other policy measures. Those options, all those options remain on the table. You know, I think it's important to note what we have done thus far in terms of, say, for example, extending the 9 p.m. closing time not reopening bars, areas that we know are high volumes of density as well as duration. So many of the measures that other states have not done are things that have been in place in Maine for many, many weeks, if not months already. Are there other options on the table? The answer is yes. We continue to evaluate the efficacy of those every single week as we think about what else can be done. Commissioner Lambert? Yep. Thanks, Jennifer. I'm going to turn it over to Steve Porter at Seacoast.
Thank you, Dr. Shaw. I know that you had spoken Wednesday and also more today about how limited information from the federal government really affects the velocity of Maine's vaccination distribution. But I'm hearing some complaints from municipal leaders here in southern Maine about a lack of two-way communication with the state on the planning and preparedness side of things. Obviously, the circumstances in Kittery or Kennebunkport are going to be quite a bit different from Augusta. And there are questions not just about when people will be able to be vaccinated, but also where and whether there will be bottlenecks because there aren't enough sites. So how are you working with municipal leaders in the southernmost part of the state and taking those regional variations into account with rollout planning?
Well, let me give you a really concrete example. Just in the past 72 hours, my team, various members of my team have had extensive conversations with the director of York County's Emergency Management Agency, Director Art Cleaves, who has been helping us think through places in York County specifically that would be suitable for vaccination, how we could orchestrate that, how we could approach that from a staffing, administrative, and other perspective. Those conversations have continued throughout the pandemic, but that's just one example of how, again, just in the past 2 or 3 days, we've had an extended number of discussions with Director Cleaves, his team, about what makes sense in York County, given the nuances, given those, as you say, region-specific considerations. There are a number of other stakeholders, not to only single out York County, but we've had similar conversations with, say, emergency management leaders across the state. Just a week or a week and a half ago, Director Pete Rogers of the Maine Emergency Management Association and I briefed county-level emergency managers across the state on where we are with respect to vaccines and vaccination planning. We asked for their assistance as we started this planning process. That conversation, too, was a two-way conversation. We've solicited input from them on what types of sites might be useful, which might be more beneficial than others. So I understand that there are those whom we haven't had a direct conversation with, but I don't think it's accurate to characterize this as one-way conversations only.
So then would you advise municipal leaders to work through their county EMAs for these conversations, or are you also open to direct municipal to state dialogue?
We're open to both, but generally speaking, the approach to activities of this nature is that the state agencies, when it comes to emergency planning and preparedness, the state agencies work first and foremost with their county level emergency management agencies, both when things come up to us as well as when we go down to them. If a hospital in York County needs more PPE, they don't necessarily call Sanford. They call the York County EMA, and they work with Director Cleaves' team, who then sends the request to us. Similarly, in reverse fashion, when we'd like to start planning and preparedness activities, our first port of call is traditionally, per the SOPs and the documents and the plans we have in place, the county level EMA. I would encourage municipal level authorities and leaders to work with their county EMA so that their views can be collated and sent up to us.
Understood, thank you. And if I may, just a quick clarifying question on a number. With these
Sure.
35 additional deaths that were throughout December, based on the 4 categories that you outlined, the 4 multi-layered approach, is it safe to assume that those 35 deaths are not associated with any of the long-term care center outbreaks that you're tracking?
Yes, that is fair. If I am wrong on that, we will correct that. But let me just glance here. I am about 98% sure, but I am now 100% sure.
Great, thank you.
Mm-hmm. And if that is incorrect, if it changes. So the other thing to keep in mind, Steve, is that we continue to receive information about cases and deaths, sometimes after they have been logged to us. It's a very, our information gathering doesn't stop once a death certificate has been received. If we later receive a report that someone in whatever age category in whatever county happened to be a resident, we will categorize it as such. At this time, Steve, the supposition that you noted is correct, but we may receive data contrary-wise later, and we will update our records accordingly. We don't stop just because we've gotten a number. I'm going to turn now to Megan at WMTW.
Thanks for taking my question, Dr. Shah. It relates to, we talked at length about when people who are in the next phase will know. I think, that's obviously a lot of people have that question, and we kind of had, doctors will reach out, healthcare providers will reach out and tell these people. But I got a question from a viewer who said, what if you don't have a doctor? Let's say maybe you get your healthcare at a clinic or something. How will you know it's your turn? And secondarily, that sort of leads me to a next question is, this may now be a difficult time, but an important time to find a doctor. What would be first steps for someone who maybe doesn't have a primary care physician, but is looking to get one now? I mean, things are different at doctors' offices. So how do you go about that?
Great. I'll take the very first part and then turn it over to Commissioner Lambrou for the latter part. If someone is receiving healthcare at a clinic or a federally qualified health center, those places have electronic systems in place to be able to identify which of their patients are over a certain age or have a chronic condition and notify them that, hey, vaccine is on its way. Let's start scheduling an appointment. So even if you don't go to a specific doctor's office, if you happen to go to a federally qualified health center or a number of other places across Maine that have primary care services, they are able to offer that type of communication to you to let you know that vaccine is on its way and it's time to start scheduling an appointment. But to your second question, Megan, you make an excellent point. And now is a great time both to get connected with the healthcare system and get a doctor. And if you don't have insurance, to sign up for insurance. I'll turn it over to Commissioner Lambrou to talk about that.
Sure. So we have in Maine a covermaine.gov initiative to try to ensure that people who need affordable access to healthcare know where to find. We have a 1-800 number. We provide information, and I recommend that anybody who is seeking help on healthcare go to covermaine.gov. It is really important as we go into this year that people do have coverage, not just for the vaccine, but also for potentially getting COVID-19, or if there's been challenges getting healthcare because of the difficulties in traveling during COVID-19. For all those reasons, get covered.
I'm going to turn it over to Evan Pop next.
Hi, Dr. Shah. Thank you. So we talked about the change the incoming Biden administration is proposing in terms of vaccines, and I'm wondering if you've gotten a sense of what other ways the change in administration could affect how states like Maine deal with COVID-19 or vaccination process. For example, would you kind of expect maybe a more centralized federal response rather than kind of more of a state-based response?
Evan, I don't. In my case, I haven't. I think it's too early to tell. As part of my role with the organization of health officials across the 50 states, we internally have discussed that. We've received some concept papers and briefing documents and had some phone calls. But given that they have not yet taken office, and I think right now they are at the concept development phase, we haven't received any firm plans about what they propose or what is high on their agenda. So at this time, I can't really comment because we haven't received any concrete proposals.
I will add, though, that looking at the organization that's getting set up, they have created an incoming team at the White House to help coordinate this effort. That is sort of the right location for something as big and broad and as important to the economy and important to the healthcare system, and have assembled a team there that has already begun to reach out to state. They already have asked us for additional information to help them in their planning. And at least I am encouraged by the engagement that we've had even before the team has taken office. So I am cautiously optimistic that we will have a more coordinated, more two-way communication relationship with the incoming administration.
Great. And then just a second kind of multi-part question. Do we have any idea what the rate of infection is, or maybe the approximate number of cases among unhoused populations in Maine? And also just kind of secondarily to that, wondering where they fit in the state's prioritization plan for vaccines, and how you're coordinating with shelters to do that.
And then again, I don't have at my fingertips the infection rate or the number of cases that have occurred within that population. But we can ask our epidemiology team to see if they've got a handle on that with respect to vaccines and where they are in that. Similarly, I don't think any discussions or decisions have been made to the extent that such individuals live, say, from time to time in a shelter for people experiencing homelessness. That's one category. For others who are truly unhoused 24 hours a day, all 7 days a week, that may put them in a different category. At this time, I don't think we've made any final decisions. As with so many things, it is a function of how much vaccine we get in.
Okay, thank you.
Over to Caitlin Andrews at the BDN next.
Good afternoon, Dr. Shah. Two small questions, I think. One, did Maine get the amount of vaccine that it was allocated this week, or did you guys get like a little less? Like, what's like the final number on that?
We got 100 more doses for next week, January 11th, than we did for this current week, the week of January 4th. We were hoping for more. We got more by a whopping 100 doses.
Okay. And I think kind of similar to a question that was asked earlier, but are you anticipating that in the next step, you know, when you are trying to get to older Mainers and moving beyond the healthcare sphere, that it will be more difficult, or that vaccinations might go a little slower, just considering that these folks are not like immediately in a workplace where they can be vaccinated, or, you know, more centralized?
That's a possibility. I don't know that we are anticipating that, Caitlin. It is a possibility. At the same time, we are hoping to be able to have locations across the state of different forms that can keep the throughput that we've seen in Maine, a throughput that I'm quite proud of relative to where we are in the rest of the other states and territories. We're hoping that we can keep that throughput up, but we know that there are going to be challenges. We know that scheduling will be a challenge. Transportation will be a challenge. We want to find locations that don't have too many stairwells. Those challenges, those considerations are some of the things we're keeping in mind right now. Again, I don't think we're anticipating that there will be a slowdown, but if there is, then that is in service of getting that vulnerable group and that population vaccinated.
Thank you. And just as a follow-up to that, are there any areas in particular that you are considering for these kind of community sites? Like, have you kind of narrowed in on any municipalities or any locations in particular?
No, not at this time, Caitlin. We are balancing, as you've sort of heard from today's discussion and others, balancing just myriad factors. It's a combination of finding places that are walkable, accessible, not far off the interstate, have parking, that don't have too many stairs, that can accommodate one-way directional flow. The list of preferences, if not outright requirements, is a couple pages long. And so for that reason, we haven't made any final determinations. Bear in mind, we are not just looking at sites that match that, but we're also trying to keep in mind geographic equity as well. So will every single site meet every requirement? Will every single site be a dream site? Unfortunately not. That's not the way this works. It's not the way it's ever worked in the world. We have to balance all of these considerations, keeping in mind operational considerations at the site level, as well as geographic equity, access, throughput, all of these things. For that reason, we haven't made any final determinations.
Thank you.
And to round us out for the afternoon, I'm going to turn to Jackie Mundry at News Center.
Hi, Dr. Shah, thank you. I think you kind of answered this a couple questions ago, so it doesn't really look like the additional 35 cases and deaths, that were reported today came from any long-term care facilities, but it does seem that recently there are quite a few deaths coming from Aroostook County. If it's not necessarily long-term care, what's going on there?
Thanks for that question, Jackie. We talked about this last week, and it bears repeating again. We're concerned about Aroostook County. That is the bottom line. The number of outbreaks in Aroostook County that are open right now, I believe numbers at 5. 4 of those, at least 4, are at long-term care facilities, and 1 of them is at Northern Maine Medical Center. As you've noted, as I've mentioned, those have generated, sadly, a number of deaths, to say nothing of a number of cases, as well as increasing hospitalizations. We're concerned about Aroostook County. That's the bottom line. We are working particularly closely with those facilities. One of the concerns among many is staffing. In other parts of the state, it may be easier to tap staff from other healthcare institutions. In Aroostook County, that's a challenge. We've also seen that in Aroostook County, many members of healthcare facilities may live with or have a spouse who, for example, is part of the EMS system or is part of the fire department, which in itself causes downstream concerns. So what's going on in Aroostook County is what has gone on in other parts of Maine, which is the virus creeping in and making inroads, and thus our concern. At the same time, having spoken with at least 2 hospital leaders in Aroostook County, one at Cary Medical Center and the other at Holton, that part of the state has had, thankfully, a longer time to be prepared. And so although cases are rising, they know what to do, they are prepared, and they are responding appropriately. We are supporting them every step of the way, whether it's with testing, PPE, staffing assistance, infection control guidance. We're supporting them every step of the way, but we are concerned.
And kind of, related to long-term care facilities, I was looking at an early release of a CDC paper, and it said high-risk exposures among healthcare staff involved in non-patient contact is kind of a problem in some other states. I didn't know if that's something that we're seeing in Maine, as well as if there's any education that needs to be done for some of these healthcare workers.
Jackie, the answer is yes. I'm familiar with the paper that you're referencing, and it squares with the experience that we've had in Maine. When we talk about healthcare providers, healthcare workers who have tested positive for COVID-19, when I talk about that number, it's not just those who are directly patient-facing, right? It is a wide array, and just to provide that number, it's 3,041. The definition that we use, generally speaking, is anybody who is part of the healthcare system, someone who may work in a custodial capacity or who may work for the food services. They are part of the healthcare system and are potentially exposed, even though they may not be direct care providers. That's what's included in that number. And the paper that you referenced emphasizes that healthcare providers of all stripes, whether they be direct care, custodial, food services, are at risk. That is one reason why in our conception of phase 1A for vaccination, we didn't just limit it to doctors and nurses and respiratory therapists, those who are in direct patient care. We expanded, or we agreed with ACIP that healthcare provider, healthcare personnel means those people in a healthcare setting who could potentially come into contact with someone with COVID or the infectious material, like those who work in custodial services. That's why for vaccination purposes, we cast that very, very big tent. That CDC paper that you reference is just one more affirmation that the choice that we made to do so was the right one.
Thank you. And then I just have one more question, a little unrelated.
Sorry, Jackie, before you go to that question, Commissioner Lambrou wanted to weigh in.
Just quickly to say, we also have learned that there is a fair amount of turnover in the staff that are working at long-term care facilities. So all the good work that we did to educate people last summer needs to be repeated. This is why Dr. Shaw, our team, has been on the phone calls again with people doing the repeat of the education. Second of all, I think we're going to look harder at our testing plans to see if we can do more testing as a means to protect residents as well as staff people in nursing facilities. There may be some new federal dollars coming our way. One of the priorities for those additional testing federal dollars is long-term care sites. And third, we do know that some of these workers are themselves uninsured. Going back to the earlier question, if people need help finding affordable healthcare, you can go to coverme.gov or call 1-800 965-746-7476 to find help.
Jackie, back over to you.
Yeah, and I actually have a testing question, so that was a good segue. So if someone tests positive for COVID-19, they complete their quarantine, but they can still, is it true that they can still test positive for up to 90 days afterwards? And if so, is that why there are more positive tests? People might be trying to get that negative test so they can go back to work or school or whatever it may be.
So, okay, Jackie, I'm going to be a little persnickety on terms, but just one thing. After you test positive, and you got to stay away from folks, that's isolation. Quarantine is a little different. Quarantine's if you've been exposed. So after someone tests positive, they've got to be in isolation, which means you're not coming into contact with anybody. You are isolated for that 10-day period at least. Now, there have been some instances of people who have continued to test positive for a few weeks. Generally not 90 days. There have been some folks who have tested positive for an extra week. In one case I'm aware of, someone tested positive after about 11 days after their last day of isolation. So on the 21st day. Those are very rare, very, very rare. It's definitely not into the 90-day period. The reason that there is this 90-day period is that we know for sure, based on some studies, that people's own immune system keeps them safe for at least 90 days, with the exception for at least 90 days. And that's why you don't need to get retested within 90 days. Do some people get tested multiple times? Absolutely. If you are, as Commissioner Lambrou said, someone who works in a long-term care facility, you're probably tested multiple times so that you, if you get positive, can be taken out of the facility and staying home so you don't infect residents. But for the most part, once folks tested positive, after their 10th or 11th day in isolation, when we retest them, they usually test negative.
Great, thank you very much.
Okay, all right, everyone. Well, thank you for your time today. We very much appreciate everyone taking some time out of their Friday afternoon to hear where we are with COVID-19, where we seem to be going with respect to vaccines, and what we're hoping to accomplish in the coming couple of weeks. I appreciate everyone continuing all of their efforts to stay up to date and informed. Today's briefing marks the 151st such briefing. I have spent more time with each and every one of you than I think I have with a lot of my family members over the past year. And so I appreciate everyone continuing to stick with us to hear truthful, accurate, factual information. Some of the news I talked about earlier today was a little bit jarring with respect to the number of deaths, but I hope the discussion around how we learn about deaths and how we continue to strive to make sure all of our numbers are accurate helps allay some of the fears that these deaths, although serious, did not all occur within the last 48 hours, but rather within the last 4 weeks. We'll continue to provide updates like that as we learn more and as we try to pull back the curtain to share with everybody how public health works in action. Until we chat again, I hope everyone has a good weekend. As always, please be kind and take care of one another. We'll talk again on Monday. Thank you.